So this is a 3-year-old male castrated lab who has a foreign body. The radiologist suspects has a linear component. We're gonna do an X-lap and see what we find. So yeah, we'll do a nice big incision, but we've saved room and draped in that we can cut around peripreputial, but we'll see if we can get away with not doing that. If you needed more exposure, like if you were doing liver or something a bit more involved, you'd probably have to go that direction because otherwise you wouldn't be able to get the exposure you need. But for an X-lap, we should be okay without it. Grace, can you ask if someone can troubleshoot the cautery? The cut's working, but the coag's not. Hi, my cut's working, but my coag's not. Sorry. I don't know if it's the pen. No, still no. You blow on it like a Nintendo cartridge. Okay, thank you. All right. Yeah. We'll clear this up in the meantime. So we don't want to create too much dead space, but we want to clear up our linea so that we know we're going in at the right spot. Male dogs tend to have really thick fibrous sub-Q, and I feel like that tricks some people sometimes when they're closing and they grab that as their holding layer. So the more you have it kind of cleared off, the better things are later when you're closing. That way you don't get fooled, because no one wants a dog whose insides fall out on them. So this cleared on up. All right, we good? I'll push the buttons. Any help? Any improvement? Nothing on this one. Take 3. All right. Well, we'll get our little. Okay. We'll get our little Uzi friends after. So we'll do a nice big tent. We'll go through our linear. And then I don't know if you had any X-laps since you've been on with us. No? So we always make sure we check both cranially and caudally to make sure there's no adhesion, especially in a dog. Yeah, I hear good sounds. Oh, it stopped. Okay. Okay, thank them. Especially in a dog that might have had surgery before, because if you had organs or intestines adhered to your linea and you slice through them, then you've made yourself more of a mess than you were going to head into in the first place. So we always check just with a little finger sweep before we cut. And then, like I said, if we were going to extend around here, our skin and sub-Q would extend around the prepuce, but our midline, like our body wall incision, would still be through linea. So that's not, we're not veering off and going through muscle there. That would be like paramedian. We're just extending this through the skin and sub-Q. We're kind of, we can see through it and staying on midline and linea for our body wall. And yeah. Yeah. Take her away. They don't know that this one's working, guys. Oh. Beeping. It did. Yeah. was M again. Sorry, Grace. We're having cautery problems. No, it's still not working. We gave it to Grace. Sorry, the cut's working for this again. Hold on, let me see. No. It's the same issue, we're just cut's working. And then yeah, for the X-Labs, we'll always take down the falciform. Otherwise, it's hard to see, it's in your way, and it's a pain in the bum.
Still on the field record? Sorry? It's still on the field record? Yes. Whenever you're done,
yeah, you can switch. It's fine. We'll pause for you. Oh, you like that noise? Good stuff. Third time's a charm. Thank you. Was it the second port or back in the first port?
I put it back in the first.
Oh, so maybe it was the pens all along?
Maybe, but we're going to have them talk across.
Yeah. Your pens have a cut function and a coag function. So they kind of do what they say. So the other ones, the cut was working, but then if we had vessels that we wanted to achieve hemostasis, then we would have been in a bit of a pickle. So we'll get our falciform out of the way, and then I'll get you, if you have a free hand, to get some damp lap sponges. So just dunk them in our saline. Perfect. Do you want to call a friend again? Thanks. But I'll get you to, yeah. We'll have to switch gloves and everything, so we'll get you back in if that's okay, unless people are going on lunch. Perfect. We'll get one on each side, and then we'll get our Balfours in, and we'll have a paper in. Sure. I'd take you can grab a 3.0 PDS and a 4.0 PDS if you want to grab those now. And just get you a double check. We'll make sure nothing's getting caught, and then I'll probably just extend cranially a little bit there so we have more room to see. We can go all the way up to our xiphoid, which is up here a bit. Yeah. Otherwise, we're in our chest. And just extend the skin a little bit. There we go, just to make it easier on ourselves. All right. Perfect. So, got our nice spleen here, and you can get a sneak peek at our guts, but maybe we'll just get the other, like explore the rest while we're here. So we'll have a peek at our liver. That looks good overall. I don't see any nodules or anything. This left lateral lobe looks a bit like rounded on the edges, and it's almost got like a little fisty friend or something, but nothing concerning. We'll check our gallbladder and we'll give it a little squeeze to make sure that it can empty and it's not obstructed. So you see it got like a little bit more flaccid there, so we know that that empties. And then we'll check the right side of our livers hiding down here. Those all look beautiful as well. We'll have a peek at our little kidney. Here's our left kidney, and you can see the adrenal right there.
Oh yeah.
See that little guy? And then we've got a few little, like, mental. They look almost like maybe they aspirated something in his belly. If he has like a little little hematomas almost. And then the other side, maybe we'll check when we're doing the GI because we can lift our duod, and that helps us visualize the other kidney. So we'll just extend this a little more so that we're able to see everything. So let's see our stomach. Up in here, she's big. It doesn't feel like there's anything in the stomach on first glance. Yeah, quite a bit of air. Nothing in the stomach on first glance. It feels like, oh, our friend is anchored like right at our pylorus right there. I can feel something. You want to have a little squeeze?
Oh,
Yeah. So there's something in our pylorus. And then I'm trying to follow that out. We might have to get this round of the way. That does look a bit corrugated, but not super plicated. So we'll see, yeah, see this plication here? Yeah. So it's anchored, stuck in our pylorus, and it's causing plication of our duod here. And now having the duod elevated like this, we can see our other kidney, which helps as well. Yep. And you can see the vena cava down there. Look how big that is. Yeah. So we might not be able to run everything because we don't want to yank on anything and bug it, but we'll just see if we can have a guess of how much this extends. So that feels like it's the duodenal flexure down here. So duod coming down from the stomach down to this point and then turning back up and then into proximal jejunum here. And then that looks like the end of it there. And so the rest is nice and normal and happy. What do you think our first step is gonna be? What do you think we should do? Should we start yanking on this? No? What do you think a good first step would be? Where is it stuck? Where is it anchored? Where is it like the first point that it's anchored? Yeah, so let's get our stomach out and we'll free up that anchor and see what we can do with the rest of it. So, it doesn't, nothing looks terrible. We'll find out. It's quite plicated, so we'll have to see, but nothing looks too angry so far. We'll just have to release it and see. So we're going to put some stays in the stomach so we can hold it up. And we'll put a little picture here. We had some, they are with my clean stuff. So I'm naughty and I use these, but I am trying to protect them because they're not, I'm using them not for their intended purpose, but I'm keeping my sharp blunts clean for closing. Yeah. All right. I'm gonna dull them. And then when people go to cut tissues, they're gonna be like, these are dull. Alright, let's pack this off so that it's nice and clean. Alright, we'll do a little one behind. We'll have to get, there's a little drippy friend from our falciform after. We have to go through 3 cautery pens before we could find one that worked. They're being, yeah, they're reaching the end of their little careers. Alright. So I'll get you to use your free hand. I'll hold this, and if you use your free hand to grab the suction, and that way when we cut into the stomach, once this is a bit big enough for you to fit in, I'll get you to suction in case there's any fluid still. Yeah. Although Grace did a very good job getting a liter 1.2 liters out preoperatively, but it's still a fair amount of fluid in there. Poor friend. No, poor guy. Alright, perfect. I'll just get in there, just gonna extend towards me because it's in the pylorus. And then we'll see if we can grab our little friend here. Put a little bib down so that we're not messy. Alright, let's see. Oh, it's gonna be too small. That'll be fine. Alright. Woo! Are you little stomach? Okay. What are you? Oh, you stink. Thank you. Alright. Yeah. That's gross. I don't want to pull too much because obviously it's down there, but I just want to reach a point that I can release it. It's a good fabric.
Said he likes to eat socks. Some fabric.
Yeah.
This one looks like a towel.
It's very stringy. Alright, that's definitely tethered. I should try to cut through it here. Oh, that's much happier. Alright.
I'm not sure if you can hear me on the audio, but this is a linear foreign body, and in dogs, linear foreign body typically anchors in the stomach and the front
Right.
ribs.
So that freed that up quite a bit.
So Jesse's just released
hold that.
the anchoring point via the gastrotomy,
Oh, that's a lot
to hopefully allow us to kind of release the
Plication.
effects.
That's a lot happier, eh? Yeah. Aw, poor little bruised intestines. Alright, so that's a lot less plicated now. Let's get our little cecum out of the way. And that's a lot less plicated now. There is a second anchor point in here. Like there's second like thick pieces in here. So we might, if everything's not too angry, be able to send it all back into the stomach, which would be quite nice. But we'll see if it moves, which this part is moving so far without too much trouble. Because in that way, we can let the rest heal without having to worry about an enterotomy. This bit's a little bit plicated still, so let's see if we can help it relax. There we go. I don't know if we're going to get away with that. We'll see. This is all straightened out, which is nice. We're just still a little plicated around the bend, but not horribly so. And then just here a little bit. But I think if we can move this bulky portion as opposed to like the really thin linear bits, then it won't hurt it. And then when you have a linear foreign body, a lot of the time the damage to the intestine will be along the mesenteric aspect. So you're always like inspecting down here. That's where all your bruising and where your potential perforations would be. So once we're done getting all this out and we go to re-inspect everything, we have to make sure that we look at that edge, because that's where you're bound to miss something, because this looks so pretty and pink, and then you're like, oh, the bruise is actually down there. But everything's sliding quite nicely so far.
So what Jesse's doing right now is just milking the foreign body from caudal or aboral to oral, in the hope that she can get it back into the stomach and just remove it from the gastrotomy. The gastrotomy is much less likely to hiss than an enterotomy.
That's the tricky bit, because we have to get it around the bend. Let me see if my little hands fit in here. Alright, it's coming.
Yeah, you can just incise the ligament too.
That's true. But it's already past. It's already past. Alright. Maybe I'll take it down a little bit.
So this is just incising along the duodenal collet ligament, just to release the kind of the tethering effect of that, to straighten everything out.
Do you think we have anything else this way still? Or do you think it's all, there's still a bit here, eh? You feel? Alright. Home stretch. Alright, she's coming around the corner, and alright. So now we just need to convince it to go back into the stomach. But we'll pack back off. We'll see if we can get it out. We're right at the pylorus again. So if I can get a bit to go through, then maybe we can convince it.
So what Jesse's done now is milk everything into the duodenum.
Do you want to
And now she's just using our tissue forceps through the gastrotomy and the pylorus to get the foreign body in the duodenum and bring it into the stomach and out.
Hopefully.
Oh.
There's the intention and the actual execution. Yeah. Nice. All right. So let's see. No, it's not. Yeah. I just want to see if I can get any of it to pass through. That felt like it popped through a bit. Oh yeah. There we go. Alright. Oh, there she is. Alright. Let's get our little bib back in. Try to keep our messes. There we go. There's no way this was enjoyable to eat, man.
That's the light and stuff too.
It's just all stringies. All stringies. Alright. Oh. There we go. Do you think it's a sock? I don't know. Or like a dish towel or something?
Maybe. I put one.
Maybe at the last. That's the thing. Like if you cleaned up a mess that had food involved and then they
Yeah.
eat it. Oh, that's a big chunk. Yeah. Alright.
That's good.
I think that might be the end of it.
So this is the
Grossness.
forearm body back here. This is removed.
So,
And
alright. Let's have a quick feel so that we don't close everything up and then have to go back in. So, intestine next page here. Everyone looks a bit bruised, but good.
so now what we're doing, which is really important, is to
You got like a
examine
little bit of bruising right
the
there,
intestine
but I
for
think
any
that still looks nice
bruising
and viable.
areas of necrosis that we're worried about.
And then yeah, like this side always looks really healthy, so you always want to make sure you're checking
So
along
the
the
linear
mesenteric.
foreign bodies, as you may be able to hear Jesse saying, the important
And
part
then
is the
Now we're at
mesenteric
the
border.
happy section. Okay. And just double check that there's not something more distal. Nope, we made it to cecum, so everything beyond this should make it out, although it doesn't look like much has made it beyond this recently. All right, so we'll get all these guys back in. We'll close up our stomach, and that'll be good for this friend. All right, Em dropped me some stuff earlier. Hold on. About 4. Do you have a 3.0 PDS there? Yeah. Yeah, perfect. I have a 3.0 monocryl for after. Just a 3.0 PDS to close up here. It doesn't look like it, no. Perfect. Thank you. And then I should be good from here. All right, thanks. All right, sorry. I keep poking you. Close this up. Got like an awkward angle.
Yeah.
So I like to close the stomach in 2 layers since we have 2 nice layers. Do you know for your stomach and intestine what your folding layer is? What all your bites should include? Yeah. So for stomach, I usually close in 2 layers. So I have my mucosa, submucosa, which is this one that I'm doing now, and then I'll do my seromuscular layer separately. But everyone's different. Some people will do like inverting patterns and all sorts of things. It's just like there's a lot of individual variation. The main thing is you're getting all your layers.
So inverting isn't necessary then for cooking.
No, it's just sometimes it looks prettier, and everyone just has their own way of doing things. I'll get you to hold that guy to hold some tension for me. And then whenever we're doing sutures on the GI, we're using our debatees because they're atraumatic forceps, and we're trying our best not to pinch or grab anything. So kind of nudging things around if you can. Obviously sometimes it's hard, but just so that you're not like pinching anything.
Yeah.
And then leaning away. And then making sure you're getting good big that positional bite. I'll probably do just one more after this. And then we'll tie that off. And then I like to do like a wee little rinse between layers just because we had some like gross juice leak out. So we'll tie this off. Perfect. And then yeah, I'll do a quick little local and then we'll do the next layer. What's up, Grace? I think starting now, because then that way, like, I'll probably do a quick abdominal lavage just because his intestines were all angry. But then after that, we'll be closing. Need us to peel it? Yeah. Okay. Okay. And yeah, I made this incision awkwardly close to me, so now I'm like at a weird angle, but it was better to be closer to pylorus because otherwise we're like reaching through the depths to try to get that guy. Is it coming out the mouth? Yuck. Here. It's not coming out this time? Maybe. Okay. I'm just going to finish closing this tummy and then I'll have a feel for you. Yeah. I don't know what it was. I'm sure the stuff you suctioned out of him earlier didn't smell that much better. Poop juice? And then you always want your suture line to like extend a little bit beyond your cut. One more. Let's add here. Alright. So, Grace, do you want to call a friend? We'll get. I keep poking you. I'm so sorry. You're a little leaky. Hello. Can we just do a liter of warm saline to flush for this friend? But we'll also just need a new pool because ours went in the gross stomach. Thanks. All right. And then you can cut your stays. So for stays, you'll just cut one side. Yep. Perfect. And let's double check while we have a minute for Grace's NG tube. Alright, you're definitely through. No, I would come in a drop more, just so that, yeah, yeah,
There?
yeah. I think that's good. And then we'll have a feel because I'm gonna make sure I didn't leave anything behind in the stomach since it's so big, and we'll count our laps. Yeah, the stomach's quite big, but it doesn't feel like there's anything in there except what feels like a little liver treat. It's like a perfect little squishy little square liver treat in there, so I think that should be okay. But the rest of it's so big, I just don't want to leave anyone behind. No, no weird rag bits left behind. All right. Dirty things over there. We'll put them. Yeah, it's a stinker. Alright, so we'll put our clean one on. We'll get our friends out, and then we'll get JC to pour that in for us. Alright. Yeah, we're ready for you. You got 9?
Got 10.
You got 10? Oh, perfect. Alright. Are you okay if we do one more liter after, JC?
Yeah.
Just because this is less clear than I thought it would be. More brown. Yeah, because it only takes a liter at a time. It's easier sometimes if you like put your hand alongside it, because otherwise momentum gets sucked up into all the little holes. So I like to give it like a little shield sometimes. Awesome. Yes, you'll get a smaller one. Yeah.
Which ones are all the non-dissolvable? I know lots of them
Yep.
non-dissolvable.
So same with proline and same with ethylon. They're all non-dissolvable of the ones that are there. Should not have a future career as a piercer.
No, he didn't want that.
He didn't want that.
Want his nose gauged today.
We spoke. Go on. Yeah, it's just an uglier color than I anticipated. Perfect. Did you have fun in the TPOs yesterday, or?
Yeah, I'm liking those. Jeff started teaching me more, I think, at the end. The most passive instruments.
Oh, nice. Right. Yeah, we'll get a bit more just so that it comes out nice and clear and pretty. And then we will close up. I'm just gonna get after this last bit of falciform where it's not like bleeding, but it'll bug me if I don't take it out, and we've got a minute to wait for JC. I just want to make sure it's not dripping. little falciform. And did we have any along here that we needed to do that we didn't do because we didn't have root and pottery then? Probably, eh? This little guy. This little guy. Alright, ready? Okay. I'm gonna do that. I'll switch to my clean hands. Okay. That's a better color. I like it.
Yeah.
So I'll set myself up a little clean area with my clean instruments. And then maybe I'll swap with you and I'll get you to switch to your clean gloves. How are you most comfortable switching gloves? You can do it so that JC pulls them off for you so that you still have your cuff again. Does that make, yeah. So I'll open it up so that you have them laid out for you. And then if JC pulls them off so you still have your cuff, then it'll be the same as when you were, yeah. Okay. There's not a ton left, but we'll get the last bit with the fresh bottle. Thank you. And last little bit. That feels pretty good. You always want to be lazy while you're suctioning, and then I remind myself that if I go to back at him tomorrow and I see fluid, I'm gonna question it. So I try to get as much as I can. But there's always going to be some on your post-op check because we can't get in every little nook and cranny. And then we'll put some omentum over our little incision. Perfect. And then we'll close up the belly. We'll do a little tummy tuck as we do it. That's probably as good as it gets for a linear in terms of being able to get everything out the stomach. Yeah. It doesn't always work that way. If you release it and not everything comes with you, then you're just doing enterotomies. And ideally, the fewer the better, but whatever you need to do for it to be safe. I think a thick piece like that, and especially because there were chunks that I could milk forward, makes it a lot easier because the chunks kind of gather the stringy bits. Yeah. But I've seen ones where it's a very, very thin, fine string, and those you can't really move that anywhere safely, and it's not even worth trying. And then I've never done it myself, but Julius has a cool, well, I mean, written up, but there's a cool like red rubber trick that you can do where you essentially like tether your foreign body to a red rubber catheter and pass that through, because that kind of like acts in the same way as when there's a chunk, so the chunk kind of gathers up the thin bits, so the red rubber kind of gathers up the thin bits and lets you kind of milk it back somewhere. Yeah. So I've seen it work a few times. You just never really want to be like putting, like cinching down on an already plicated region. So if you ever like pull on anything and it just doesn't, like if it doesn't slide easily, then stop and reevaluate. Otherwise you're potentially going to do more damage, and then you're setting yourself back as opposed to giving yourself a shortcut. We'll get him zipped up. We'll give him a little tummy tuck with this suction, and then we can turn the suction off and our brains can breathe.
About the scissors.
Yeah.
Jeff also told me I was supposed to use the tips.
Yeah.
But I've also heard in the past not to use tips because you can blunt them.
Well, it depends what you're cutting. Like to cut suture always, you have like much finer control with the tips.
Yeah.
The reason I was purposely not using the tips was because I was using Mayo scissors instead of suture scissors, which is a naughty thing, but our packs only come with one thing of suture scissors, and I was saving them for my clean, which I guess theoretically, instead of being naughty, I could just ask for an individually wrapped pair. But for those, you're using the tips just so that you have finer control. And then it kind of just depends what you're doing. Like sometimes you saw the like when you're opening the linea, sometimes you're kind of further up along the scissors doing a bit of a glide. But really depends what you're cutting and what you need to be able to see and feel, and how fine of control you need. But I mean, if you're cutting tissues and your scissors are getting dull, then maybe you need to send your scissors out for sharpening, which we do on a semi-regular basis. But the main no-no would just be using tissue, like scissors that are meant for tissues, for suture or whatever else, using instruments for different purposes that can damage them, which we sometimes are naughty and do. Sometimes naughty people, like those you worked with yesterday, will use Fraser tips to bend pins or silly things like that. All right, Grace, how's he doing? Really good. Really good? Time is good? Yeah. You want to do the sub-Q and swap? Okay. All right. I'll give you these. I'll give you those. All right. And then, I forgot to do a tummy tuck. It'll be okay. All right. And let me know if you need to chat through anything, like burying your knots or anything like that. But if you remember, then go for it. Usually, remember how we were talking about like not pinching organs and stuff? I would avoid grabbing skin and grab your sub-Q. Yeah.
Okay.
But I I'm naughty about that sometimes too. So sometimes you were at places where someone's like giving you a little tap on the hand every time you do it. You need that, otherwise you like, yeah, you just like forget, yeah.
Sometimes you just get in the moment.
Oh yeah. Well, especially for like starting your row and ending your row, you're like,
Yeah.
I just need just grab something.
Yeah, especially if you're running out of stuff.
Yeah, when you've like left yourself a little nothing. Neat. Perfect. And then yeah, and boy dogs do have that nice like thick, well-defined sub-Q, so it's quite nice. But you can see how it could like trick you into thinking you're doing linea, and you're like, oh. Okay, let me know if you want me to run it for you at all.
You want to? I feel like when it's long, it's usually like just
Toss it
But
out
when
of the
it
way.
gets short, I'm like, ooh.
Yeah.
Really?
Is this your first non-ER rotation?
Yeah.
Yeah.
Oh no, it's not. Opto. I have.
Oh, opto. Okay.
But it was so short, I forgot.
Goes fast.
It goes so fast, especially because it's only 4-day week too. So it's like.
Yeah, they have a shorter week.
Yeah, everything is so quick over there. And we had short days because her brother had her babysitter for her dogs.
Oh.
Around, so she had to leave early.
To get home to them. Oh, she's got like a ton of animals.
Pups,
Yeah.
And some ponies.
Do you like opto?
I do really like opto.
Nice.
It's really cool. I've only done. That's kind of my first opto experience, which is nice.
Which school were you?
Calgary.
Calgary. Okay.
Yeah. We did have an opto rotation, but I didn't get it.
Oh yeah, it's one of those ones that's like really competitive, isn't it, to get into? Because everyone wants it. Yeah.
Everybody wants an opto rotation, which makes sense. You see a lot of ice.
Yeah.
If you're a GP or if you're running your specialty.
Yeah. I always felt like bad at OBC didn't always have opto, and then they didn't have derm, and I don't think many universities have dentistry, so it's like all those things that are like your day-to-day in GP, and you're like not getting rotations unless you go out of your way to find them, which is harder. Have you thought about like what's next after internship, or you're just like, nah, I'm just gonna take it day by day?
I've been debating so much. When I first applied, I was like, I do want to specialize, but everything I did I loved, so I was like, oh, this is hard. And I was like, well, maybe I should practice GP for a while so that I can do all those things.
Yeah.
And then
sometimes ER is good for that too, because you get to do a bit of everything.
That's true. Yeah, sometimes ER is good for that.
Especially like here, we don't have like our ER vets don't do surgery, but there's some ER hospitals where the ER vets do out of hours surgery. So then you'd get like a little bit of everything. Maybe not as like, then you get to do like the jack of all trades kind of life, where you get to do a little bit of everything.
Yeah.
But then you don't really get a choice. It's like what comes in the door.
Exactly.
Then some days are really great and some days are awful, and some days are awful because they're busy and some days are awful because they're boring. Yeah.
Hard to win sometimes anyway.
Yeah.
But yeah, I thought, there's so many things that I just want to do, and I was hoping an internship would help with decision-making process.
Hopefully it will.
I don't know.
It's still early days. It's just hard because the way the system's set up, it seems to like it makes you kind of pick right off the bat, right? Like
Yeah, it does,
you need to start working on applications in like October, and then it's like, okay, I've had 3 months to decide what I like, and I haven't really even like rotated through everything yet. Yeah.
I thought about surgery for a long time, but then I was like, oh, I don't know. I feel like it's so competitive. It's very
Yeah, it's
I met some interns who interned for 5 years before getting a residency match, and I was like,
yeah, it's
I
a
don't
lot.
think I want to do that.
I
Don't
just
wanna risk it.
yeah, it just depends. I guess it depends.
Yeah.
If you really want something, then
That's true. Yeah.
then it.
Then you go
You
for
mean
it.
it still feels long, but you just keep going.
Yeah. At least you're doing what you enjoy at the time being, though.
Yeah,
Just
Just-
not the easiest job.
not the easiest
Intern's not
journey.
always
Yeah,
easy.
and then all like more like kind of surgery opto vibes or like medicine at all or no?
Not
No.
really
Okay.
medicine. I'm not
Not
a huge
medicine.
fan.
I
Opto, I like working with my hands. So
Yeah.
opto, dentistry, surgery,
okay.
all of those I really enjoy.
Yeah. Are you doing a dentistry rotation? program?
I'm not scheduled yet, but I'm gonna ask her if she can add it to the
Yeah.
schedule. And I was thinking maybe opto. I have a little bit of background in opto, but not animal opto.
Okay.
I did breast cancer research at McGill for 2 years.
Oh, cool.
Yeah. So I was like, oh, opto's kind of fun. I mean, onco's kind of fun, but
Yeah.
I guess onco surge.
Yeah, you
And
can
I
do surgery.
have-
Then you have to do surgery and then
Yeah.
surgery.
Oh, really? Oh,
Yeah.
no. I thought you could do it all at once. Okay. maybe
Well,
not.
you like so Julius and Sarah are surgical oncologists, so they
Yeah.
did surgery residency, and then once they were boarded surgeons, they did like you would do a fellowship
Oh, I
in
see.
surgical
Okay,
oncology, so it'd
okay.
be an additional training program
That
out
makes
the other
sense.
end. So it's like tacking on even more years.
Even more. Oh,
Yeah.
okay. Well, maybe.
So like same as like what Lana likes the OMFS,
Oh,
the
okay.
oromaxillofacial surgery.
Yeah.
So like for that you would either do surgery or dentistry, and then once you're at the other end of that you would do a fellowship in OMFS. So you're just signing up for a longer you're like a forever student. It's like the people who do PhDs or multiple PhDs, or you always meet people who are like double boarded or something, and you're like,
Yeah, it's
how did you
crazy.
do
It's
this?
crazy. Yeah, that's a lot. Oops. I do love school, but I'm at the point where I'm like, I've been in school for 12 years.
Yeah.
I'm kind of getting tired, I think.
You know, you have a loop.
Going underneath.
Let's see if we can get him out. Okay, I'll hold your loop for you. Perfect.
Yeah. And then starting the internship, I was like, oh, I'm so tired. I want a break. I'm like, well, if I need to decide, probably be sooner than later.
Yeah, and there's quite a bit of like, there's not really ever any like breaks in between. Like usually like one program ends and then the next one starts within like a week or so.
Yeah, which is
And then you're often having to like move during that time as well.
Exactly.
So it keeps you going.
Yeah.
It's like a 4-year, however plus year adrenaline rush, and then you finally like at the end of it you're like, what do I do with myself? Alright. Ooh. What are your feelings about intradermals? You want to give it a go?
Yeah, sure. I'd
Okay.
like to. I'm always a little bit slower at intradermal, but Elias probably doing it.
He's doing good?
Yeah.
Perfect.
Going with the same line.
I don't know. I'm trying to think if it'll be easier to start at this end, just because this end's a bit more like floopy. You know what I mean?
Yeah,
Like the
I see
skin's
what
more
you're saying.
floopy, so you
Yeah.
might get an easier start at that end if you want to switch sides again. Sometimes I do that just to make my life easier. Yeah, I don't. The floopy skin just like it's like running away from you. Yeah. to get the angle. Yeah. I don't know. I've tried it like multiple times and it just never, I never like got the feel for it. Like it just doesn't feel right.
It is.
And I'll start like doing it and then I'll like get to like halfway through my line and realize I'm just like back to how I was. So I just gave up. We did, yeah. We had 10. And the gauze never came out of the box, but I took them out now. I can give them a quick count. 1, 2, 3, 4, 5, 6, 7, 8, 9. I think we should keep the foreign body because some people like to see it. I don't know why, but they do. So we keep it in a, yes, keep it in like double bagged or something. Let's do 60. He wasn't super dehydrated. We gave him a few boluses. I think we're good. The other thing I'll do for my intradermal sometimes is like use my fingers instead of my forceps to like stretch things out or like kind of push it so that you like see the edge and you can, yeah. And then you can kind of like catch it and use your finger to like flip it out and then you don't have to worry about grabbing things you're not supposed to grab. Yeah. And then you like, yeah, it keeps you like quick superficial right at the edge, which is nice. So.
I find my bites and intradermals get really
Big or
long?
Yeah.
It makes my thing all puffy and lean.
Can do like a more wrist. More wrist. Yeah. Sometimes it'll be like the diameter of the needle as well. Like the little 4-0 monocurl on the tapered needle has like a really teeny tiny delicate needle with like a really kind of acute, like quite curved diameter, and it's really nice for doing like cat skin and stuff like that. You can get nice little bites and like it's got a nice like fine tapered point, so you can get it that way, which is good.
Do you have tricks for grabbing your suture needle with the little rat tooth ones? It's so hard. I can never get it.
I don't know, you just get used to it after a while. I don't know.
I always struggle with that one for some reason.
Yeah.
And I don't know why.
Sometimes we have a few pairs of ratties that are floating around that like don't close nicely, and then you like think you're going crazy and you're dropping everything, and then you realize like if you just like try to close them on their own, you're like, oh, these are the naughty ones, like the bad ones. So sometimes like have a peek, because there's some that like they just don't oppose properly because someone's done something silly with them and they've like gone off alignment. But otherwise it's just, I don't know, you just get used to it, I guess. You just do something a cajillion times over and your brain and your body learn how to do it. It's usually like, like you spend most of your internship suturing and suturing and suturing, so
That's kind of good.
then it like, it made me think of like, you know, like Karate Kid, like Mr. Miyagi, where you do like the wax on, wax off, and then eventually they're like, it was like, I was teaching you karate all along. It's like you do all your suturing and things, and then eventually you're like, oh, I could use these skills.
These are very good practical hands-on skills.
Yeah.
Actually, surgery.
Exactly. bolus. Okay. Perfect. I think 60 will be okay. I'm hopeful that he starts eating, and then like his distal to his colon and distal to the foreign body looked really boring. Sometimes it's like full of like, you're like, oh, impending diarrhea. And then you're like, okay, this guy's gonna have a lot of losses. I want high fluids. But this guy's like, everything was really empty and boring. So I'm hopeful that he doesn't just like blow out with diarrhea. His losses are done and he can eat. He looks like the type of boy who would eat. So we'll see how he does. And then do you remember your timeline for like GI dehiscence?
5 days, 3 to 5 days.
Yeah. So that would be like going back to M&M rounds this morning, an important communication thing for your owner. So letting them know that that's the timeline we'd be keeping the closest eye on him. Because you would hope that most patients would be home in that timeline. You're like, you know, that's the scary time, but I'm not gonna like keep them here just because something could happen if they're otherwise doing well. And so, yeah, you warn the owners. What do you think the first sign is usually, like the kind of hallmark thing that you warn them to watch out for?
Like supreme lethargy, vomiting, diarrhea.
Yeah, usually vomiting is like the big red flag that I warn them about. So I say like, you know, he's going home. If I'm doing the discharge, I'll say today's day 2, starting tomorrow. You know, we're worried about, that's our kind of window that we'd be worried about GI dehiscence. Yeah. Why don't we keep a close eye on him? If anything seems off, give us a call. If he vomits, just come in and get him checked out. But yeah, vomiting would be the first one, the red flag, and then otherwise, yeah, like you said, lethargy. You know, if he's like eating when he's here, or eating and then he stops, like goes off food again, stuff like that would be the same signs. Just some dogs are so stoic, like they don't give a ton away, and then some dogs will like eat no matter what. So especially like a lab or something like that. But vomiting, usually you can get them, you can catch them. Yeah, it's tricky. Those are quite like bulky looking, as opposed to like we have some finer tipped instruments. It looks beautiful.
Yeah, we've been going so slow.
That's okay. You get faster the more you do it.
That's practice.
And you've got what, 3 weeks with us?
3 weeks. Yeah.
So
That's true.
do a little something every day, and then at the end of the 3 weeks, you're like, oh, this is so easy.
No, it's fine. I love surgery. No one has to have. I haven't seen anything too crazy yet.
Oh, it'll come. There's like, yeah, things come in waves. There was like a few weeks in a row we were just doing like so many thoracotomies. It was.
Oh, really?
Yeah. And there was like bad porcupine season this year. We had like, we had a few where we had to like we literally like pulled quills out of beating hearts. It was insane. We had some friends that impaled themselves on sticks this year. Yeah, we had some barbecue skewery friends. All sorts of fun things. We had
here on the surgery side, because in the ER we'll be like, yeah, they can migrate. Doesn't always happen, but they can. And I've never heard of a case that actually migrated.
Yeah, no, we've had a few. Yeah, They're actually they were like a brother and sister dog, like the same family.
Yeah.
And they both got quills, and they both had to have sternotomies to get their quills out of their lungs and heart.
Oh my God.
And I think they came back for Dara's like positively miraculous party she does every year. I don't know if she's told you about that.
No, I don't know.
Every year she'll like gather medical marvels, like some of the cases that stood out.
Yeah.
Mostly like people that we've kept in touch with, just because it's harder to track people down if we haven't been in touch, but people we've kept in touch with, or cases that like stood out.
Yeah.
And she'll have like a little party for them.
Oh my
And like she does a little slideshow where she like
That's so
presents their
fun.
cases. Yeah, it's really cute.
That's really fun.
Yeah, I missed last year's because I was off studying, but
Oh, okay.
I think they were at that, or at least they were invited to it. And then it was funny, like the first year she did it, there was like an Irish wolfhound, and like there was like a cat on a harness, and they were like sniffing each other. It was so funny. It's just like this room. It's usually like some of it too, like she'll pick people based on like animals that we know are friendly and wouldn't be too stressed out by the situation. There's a few where we like, you're invited in spirit, but like please don't bring your cat, it's too stressful.
Yeah.
So
that's really fun. Is it here at the hospital? Or
Yeah.
Is she hosts? Okay.
yeah, just in the boardroom. Oh, it's fine. Yeah, just like usually she'll do it once a year, like kind of March, April. So that way it gives us like some time to like come up with a list. Like she'll usually come to like all the services and be like, can you remember like any like crazy cases this year? So
That's so fun. I'm
Yeah.
excited to see what comes up this year. Do you do a lot of space?
we don't do a ton. Sometimes it will be with something else.
Yeah.
We'll do them if people come for lap. We'll do them more if like people come for anesthesia more than surgery, if that makes sense. Like if it's like a patient with like a cardiac issue and they need to see like cardio and they need to be monitored by an anesthesiologist, then they'll come here and we'll do the spay because they're here. But we don't have a lot of people who come just for a regular spay.
And that makes sense. That makes sense. It's usually like additional secondary to
Yeah.
some of the classes.
But or like, you know, if they have like, if they need like their knees done and then they want to get spayed at the same time, or laparoscopic. There's a few like local GPs who are doing lap spays, which is good. Yeah, I don't know if anyone else is doing lap pexies locally that I know of, but I wouldn't be surprised. There's a lot of people just doing lap stuff generally. Oh, I'll hold your loop. And then, yeah. Or like, I honestly, there's a chance that Graham does more space than us.
Really?
Yeah.
Where's
But-
Graham doing space?
Well, because like if like puppy